Welcome to a new deep dive. This segment is specially produced for the Critical Care Education Foundation's Knowledge Hub project. Our aim here is really to augment your learning, supplementing the other great material and self-assessments you'll find on the CCEF Knowledge Hub. Today we're diving into, well, a really challenging area in the ICU, neuromuscular disorders.
Indeed. These conditions, they often pop up with acute or maybe subacute weakness, and crucially, they hit respiratory function hard, which means, getting the diagnosis right quickly and managing things precisely is just absolutely vital for survival in critical care.
Right. So our mission today is to equip you with those critical insights, going beyond just the textbook to give you clinical pearls, really drawing from the latest research and expert consensus. We'll be distilling key info on conditions like myasthenia gravis, Guillain-Barré syndrome, and that really pervasive challenge of ICU-acquired weakness. So let's unpack what you really need to know. To start, maybe let's just frame what we mean by neuromuscular disorders and the critically ill. What exactly are we talking about here, and why are they such a big concern in the ICU?
Yeah, good place to start. At its core, neuromuscular weakness really stems from problems anywhere along the motor unit. That could be, the lower motor neurons up in the brainstem or spinal cord, or it could be the peripheral nerves, the neuromuscular junction itself, or right down to the muscle fibers. In critical care, sometimes these disorders are the primary reason someone's admitted. Other times, unfortunately, they develop as a complication of the critical illness.
And when we think critical care, breathing, as you said, is often front and center. So how do these disorders directly impact a patient's ability to breathe? What are the key things we need to be watching for?
Respiratory muscle weakness. That's hands down the most common reason these patients need ICU care. We're mainly concerned with three key muscle groups. First, the upper airway muscles, think palatal, pharyngeal, laryngeal, lingual muscles, weakness there. That leads to trouble swallowing secretions, maybe a hoarse voice, and a really high risk of aspiration.
That's a huge point. If they can't protect their airway, well, everything else is secondary. So difficulty with secretions, check. What about the muscles actually doing the work of breathing in?
Exactly. So second group, the inspiratory muscles, primarily the diaphragm, of course, but also the sternomastoid, scales, peristernal intercostals. If these are weak, you see tidal volume drop. You might see that classic paradoxical abdominal movement or just, heavy use of accessory muscles. And a subtle sign, but important, is nocturnal hypoventilation, especially during REM sleep when those accessory muscles kind of check out.
Okay, and then getting air out. That's crucial for coughing, clearing things out, different muscles again.
It is. Third group, the expiratory muscles. So internal intercostals and the abdominals. Weakness here really cripples the ability to cough effectively and clear secretions. That just ramps up the risk for pneumonia and other nasty lung issues.
So how do we actually get a handle on this decline, objectively measure it? What are the practical numbers, the parameters you should be trending in the ICU? What are those critical thresholds?
Trending. That's the absolute key. It gives you the dynamic picture, not just a snapshot. We lean heavily on a few things. First, forced vital capacity, FVC, or sometimes slow vital capacity, SVC. Normal is around 50-70 millicuration. Now, here's a clinical pearl. If it drops to about 30 millicuries, that flags a weaker cough, trouble clearing secretions. Below 20-25 millicuries, that's your warning sign. Impaired sighing, respiratory failure is looming. They need the ICU. And the real action point, below 15 millicurie, mechanical ventilation is almost certainly needed then.
Okay, so 15 millicurie is that critical line in the sand for intervention.
Pretty much. And another clue. If their supine VC drops by 30% or more compared to upright, that strongly suggests severe diaphragmatic weakness.
That's incredibly useful, a clear sort of tiered warning system. What else do we use for, say, inspiratory strength specifically?
We also measure maximal inspiratory pressure, PI max, sometimes called NAF, negative inspiratory force. This tells you directly about inspiratory muscle strength. If a patient can't maintain a PI max greater than, say, -20 to -25 centimeters of water, that usually means they need mechanical ventilation. And values less negative than -30 suggest, a concerning risk of building up CO2 hypercapnia.
Right. And for the cough, the expiratory side.
For that, we look at maximal expiratory pressure, MEP. This assesses expiratory muscle strength, which powers the cough. An MEP less than 40 centimeters of water makes an effective cough really unlikely. They just can't clear things well.
What about blood gases then? Are they an early warning sign we should jump on, or is it more complicated?
That's a really important question in critical care. Blood gas changes, things like hypoxemia and hypercapnia, they're late signs. Patients who still have a good respiratory drive, they'll often compensate initially by breathing faster, keeping CO2 normal right until the muscles really start to fatigue.
So don't wait for the blood gas to sound the alarm.
Exactly. Rely on your clinical exam, rely on those vital capacity trends. We also need to assess for bulbar involvement clinically, checking swallowing, speech, because direct strength testing there isn't really practical. And I should mention, diaphragmatic ultrasound is becoming a pretty useful non-invasive tool as well to check for diaphragm paralysis.
Okay, let's shift gears a bit. Let's talk about one of the most common and critical neuromuscular disorders we see, myasthenia gravis. What makes it unique, especially in the ICU? What brings these patients in?
Right, myasthenia gravis. It's an autoimmune condition where the body's own antibodies attack acetylcholine receptors at the neuromuscular junction, specifically on the muscle side. Fewer working receptors means weaker muscle contractions. It's actually not super rare, maybe 150 to 250 cases per million people, and it tends to hit younger women and older men, sort of a bimodal pattern.
So, clinically, what does that look like, and how does it land someone in the ICU?
The absolute hallmarks are weakness and, importantly, muscle fatigue that gets worse with activity and fluctuates over time. Often it starts with the eye muscles causing double vision, droopy eyelids, or the bulbar muscles leading to facial weakness, slurred speech, trouble swallowing. But it's the respiratory muscle weakness that frequently triggers what we call a myasthenic crisis. That's the severe respiratory compromise, inability to handle secretions that demands ICU admission. About 15–27% of MG patients go through this.
How do we actually confirm the diagnosis, especially when someone's critically ill, maybe septic, other things going on?
Yeah, it relies on strong clinical suspicion backed up by tests. Bedside, there's the simple ice pack test for mectosis cooling, can temporarily improve neuromuscular transmission, so the eyelid might lift. Then serology is key. About 85% of patients have detectable antibodies against the acetylcholine receptor, AChR. And here's a clinical point. For those who are AChR negative, testing for MuSK antibodies is important. They're found in 30–70% of those seronegative patients. And MuSK-positive MG often means more severe bulbar and respiratory problems. We might also check for striated muscle antibodies like titin ryanodine receptor, which can hint at an underlying thymoma or late-onset MG.
Okay. And electrodiagnostics, what do they add?
Electromyography EMG shows characteristic findings. Repetitive nerve stimulation often shows a drop, a decrement, in the muscle response amplitude. Single fiber EMG shows increased jitter, meaning variability in transmission timing. And routinely, we'd get chest imaging to look for a thymoma or thymic hyperplasia and screen for other autoimmune issues like thyroid disease, as they often travel together.
Let's focus on that myasthenic crisis when things really go south. What usually tips them over the edge? And how do we manage it acutely, especially differentiating it from a cholinergic crisis?
Right, the crisis. That means respiratory function is threatened or failing. The most common trigger by far is infection, about 29% of crises. Medications are next, around 10%. But surgery, pulling back too quickly on immunotherapy, even paradoxically, starting corticosteroids can sometimes precipitate a crisis initially. So job one is always hunt for and treat any underlying infection and stop any offending drugs. And when someone deteriorates acutely, you absolutely have to rule out other mimics or contributors. Electrolyte problems, check the sodium, potassium, calcium, phosphate, magnesium, thyroid issues, and critically, cholinergic crisis. That's weakness from too much anticholinesterase medication.
That differentiation is key given they're often on those meds. So once we're confident it's a myasthenic crisis, what's the treatment approach?
For the acute crisis, the mainstays are immunomodulating therapies, plasmapheresis, PE or plasma exchange, and intravenous immunoglobulin, IVIG. Now, clinical trials suggest they're probably equally effective overall, but there's often an expert consensus, or maybe a feeling, that PE might work a bit faster or be slightly more potent, especially in really severe crises. But the choice has to be individualized. You'd avoid PE if the patient is septic or hemodynamically unstable. You'd be cautious with IVG in renal failure, hypercoagulable states, or known hypersensitivity. Typically, PE involves 4 to 6 exchanges over 1 to 2 weeks. IVG is usually dosed at 1 to 2 grams per kilo total, given over 2 to 5 days.
And what about their regular cholinesterase inhibitors like pyridostigmine? Keep them going, stop them.
Generally, in a crisis, it's recommended to hold these medications. It helps reduce secretions, which can be a major problem, and makes it easier to assess their underlying strength without confounding from the drug. Plus, it avoids accidentally pushing them into a cholinergic crisis.
Okay. What about longer-term management? And I'm really interested in the newer biological therapies.
Yeah, so longer-term immunosuppression is key. Often we start with corticosteroids, like prednisone. They work well in over 80% of patients, but you have to warn them about that potential for transient worsening at the beginning. Then we use steroid-sparing agents like azathioprine or mycophenolate mofetil. They take a while to kick in, though azathioprine can take 6 to 12 months for full effect. Cyclosporine is another option, but you need to watch kidney function and drug levels closely.
Right, the standard stuff, the biologics, that's where things get exciting, isn't it?
Absolutely. This is really changing the game for refractory patients. Rituximab, which targets CD20 on B cells, has shown good efficacy, especially it seems in MuSK antibody-positive MG, maybe even better than an AChR-positive. Some are even suggesting using it earlier might lead to quicker remission.
And targeting the complement system.
Yes, eculizumab, a C5 inhibitor, was a big step forward for refractory AChR-positive generalized MG. It blocks that final complement pathway that damages the muscle membrane, and it works fast, often showing improvement within 4 weeks, and there's more coming down the pipeline. Other complement inhibitors like ravulizumab and zilucoplan, plus a whole class of scRNN antagonists like efgartigimod and rozanolixizumab, which work to lower pathogenic IgG antibodies. It's a really dynamic area.
Fascinating. Lastly, for NG, let's quickly touch on perioperative management. Sounds like a minefield.
It requires really compulsive, careful planning. A neurologist absolutely has to be part of the team. Goal 1 is optimize their MG status before surgery. You have to be super cautious with sedatives and opioids, high risk of respiratory depression. Neuromuscular blockers. Avoid if you possibly can. If you must use them, use non-depolarizing agents at much reduced doses and have sugammadex ready for reversal. And another key point, avoid aminoglycoside and fluoroquinolone antibiotics. They can worsen weakness. Keep their steroids going, maybe a stress dose bump. For less stable patients, pre-op PE or IVAG might offer a temporary boost, though not always needed if they're well controlled.
Okay, let's move on. Another major player in the ICU, Guillain-Barré syndrome, GBS. How does this differ from myasthenia? What are its key features that should make us think GBS?
Right, GBS. This is an acute inflammatory demyelinating polyradicular neuropathy, so it's attacking the myelin sheath around the nerves, primarily. Often triggered by an infection beforehand, classically Campylobacter jejuni that accounts for maybe 26–41% of cases, or CMV, about 10–22%. The idea is molecular mimicry, antibodies cross-reacting with nerve components. Unlike MG's fluctuating weakness, GBS is typically a subacute progressive weakness. Classically ascending starts in the legs, moves up. It usually peaks within about 4 weeks. Cranial nerve involvement is common, maybe 45% of cases, facial weakness, swallowing difficulty, slurred speech, and a really crucial, sometimes overlooked feature is autonomic dysfunction. Wild swings in blood pressure, heart rhythm problems, gut motility issues like ileus. This is common and a major cause of morbidity, even mortality. You have to be vigilant for it.
How do we nail down the diagnosis? Distinguish variants. What are those classic findings?
It's largely a clinical diagnosis, but supported by tests. CSF analysis is key. You look for that classic albumin cytologic dissociation. High protein, but normal white cell count. This often develops after the first week. Electrodiagnostic studies, nerve conduction studies, and EMG are crucial. They'll typically show signs of demyelination, slowed conduction velocities, conduction blocks, or in the axonal variants like AMN or AM Messingen, they show primary axonal damage instead. And remember the variants. Miller-Fisher syndrome is a well-known one. Ataxia, arflexia, ophthalmoplegia, eye movement problems. It's strongly linked to antibodies against GQ1B ganglioside.
And managing GBS in the ICU, what's the immediate focus? How does immunotherapy fit in here?
Management is really about supportive care, especially respiratory support and immunotherapy. Ventilatory support. Intubation is needed when that vital capacity drops to around 15 millichiaja, or if they're clearly struggling with secretions or their CO2 is climbing. Weaning often requires getting the VC back above 15 millichiaja and their NIF stronger than -25 centimeters H2O. And we need to be prepared for potentially prolonged ventilation, often more than 4 weeks. For immunotherapy, again, it's plasma exchange, PE, or IVG. Both are proven equally effective in speeding up recovery. PE is usually 4 to 5 exchanges over 1–2 weeks, ideally started within 7 days of onset for best effect. IVG is that 2 gigagram total dose over 2 to 5 days. IVG is often preferred just because it's easier to administer, especially if the patient's hemodynamically unstable. Important note, there's no benefit to using both PE and IVG together or switching if one doesn't seem to work immediately. And here's a massive clinical pearl for GBS. Corticosteroids do not work. They might even slow recovery. So definitely avoid steroids in GBS.
Right, no steroids. Good point. Beyond the weakness itself, what other big complications do we need to anticipate and manage proactively?
Well, DVT and PE are major risks, so prophylaxis is essential. And as we mentioned, that autonomic instability is a huge concern. Requires really close monitoring and management of blood pressure, heart rate, rhythm. It's a frequent cause of death if not managed well.
What other acute neuromuscular conditions might look like GBS or also land someone in the ICU needing similar support?
Yeah, the differential is important. Consider West Nile virus, acute flaccid paralysis. It can look like GBS with acute, often asymmetric weakness, but sensation is usually okay and reflexes might be present. The lesion is more in the spinal cord's anterior horn cells. Diagnosis is via WNV antibodies in CSF or serum. Unfortunately, no specific treatment exists.
Okay. What about toxin-related things?
Absolutely. Botulism, caused by the Clostridium botulinum toxin. This typically causes descending paralysis, starts with bulbar eye muscles, then moves down symmetrically. Can mimic Miller-Fisher early on. Diagnosis is by finding the toxin in serum, stool, or suspect food. Treatment is supportive care, often long ventilation, like 7 weeks, and antitoxin if given very early. Then there's tick paralysis. Ascending paralysis, again, caused by a neurotoxin from certain ticks. The absolute key is finding and removing the tick. Improvement is usually rapid after that. You have to look everywhere for that tick.
Got it. Find the tick. Are there more common things too, like medication side effects or metabolic issues?
Yes, definitely keep those in mind. Drug-induced myopathies, things like statins or high-dose corticosteroids themselves can cause weakness. And electrolyte problems, severe low potassium or high magnesium, for instance, can cause profound weakness needing ICU care. And don't forget organophosphate toxicity from pesticides, nerve agents. Inhibits acetylcholinesterase, floods the system with acetylcholine, causing both muscarinic symptoms and nicotinic ones, including significant muscle weakness.
Okay, so moving beyond those specific named conditions, there's this whole broad, almost umbrella category, ICU-acquired weakness or ICUAW. It develops during critical illness. What exactly defines it, and why is it such a big deal for patient outcomes, even long after they leave the ICU?
ICUAW is essentially clinically detected weakness in a critically ill patient, where you can't pin it on anything else but the critical illness itself.
Yeah.
And it is a huge problem, often underrecognized. It leads to prolonged mechanical ventilation, longer ICU and hospital stays, and really significant long-term morbidity.
Huh.
We're talking severe deconditioning, lasting muscle loss, even persisting cognitive problems. It profoundly impacts quality of life and functional independence, sometimes for years.
So what are the different flavors, the phenotypes of ICUAW? How do we sort them out?
We generally classify it into a few main types. There's critical illness, polyneuropathy, CIP. This is primarily an axonal sensory motor nerve problem, usually affecting distal limbs more. You see weakness, reduced or absent reflexes, sensory loss. Nerve conduction studies show reduced signal amplitudes, CMAP, SNAPs. CK level is usually normal.
Okay, that's the nerve type. What about the muscle type? I hear that's more common.
That's right. Critical illness myopathy, CIM, is thought to be the most frequent form. This presents as more generalized flaccid weakness, often affecting proximal muscles just as much or even more than distal ones. Sensation is typically normal. Electrodiagnostics might show low motor amplitudes, maybe signs the muscle isn't easily excitable. If you biopsy the muscle, you often see this selective loss of myosin, the thick filaments. And unlike CIP, the CK level can be elevated in about half of CIM cases.
And sometimes it's a mix. Plus, didn't he mention something about neuromuscular blockers earlier?
Exactly. You can have critical illness neuromyopathy, CIPNM, which is just a combination of both CIP and CIM features, often seen with sepsis. And yes, there's also prolonged neuromuscular junction and MJ blockade. This is rarer now, but can happen after prolonged use of non-depolarizing blockers, especially with kidney or liver dysfunction or other factors like high magnesium or acidosis. Presents as flaccid paralysis, often including cranial nerves mitotosis, eye movement issues, facial weakness. Repetitive nerve stimulation studies confirm this one.
So what are the big risk factors for developing any form of ICUAW? What should clinicians really be watching out for?
Key risks include having multi-organ dysfunction, severe sepsis, or SIRS. The longer someone is on mechanical ventilation, the higher the risk. Now, historically, hyperglycemia was strongly implicated, and tight glycemic control was thought protective. That link is, well, less clear now in broad ICU populations due to risks of hypoglycemia with tight control. It's more nuanced. And similarly, corticosteroids and neuromuscular blockers were heavily blamed in the past. Recent data, especially with agents like cisatracurium used for ARDS protocols, suggest the link might be less direct or maybe not causal in many cases, or at least inconsistent. Prolonged NMJ blockade specifically is largely preventable with appropriate choices and monitoring these days.
Given how devastating ICUW can be long-term, what are the best strategies we have now for prevention and treatment? What actually works?
Well, the evidence for specific targeted interventions is still a bit limited, unfortunately. So a lot of care is supportive, focusing on preventing any secondary injury. As we just touched on, that idea of strict glycemic control specifically to prevent ICUAW isn't really recommended anymore for general ICU patients due to the associated risks outweighing potential benefits in large trials.
Okay, so if tight sugar control isn't the magic bullet, what is the most critical intervention, the one thing we really need to push for?
Without a doubt, early mobilization. This is absolutely crucial. Study after study shows that getting physical and occupational therapy involved early, even while patients are still on the ventilator, is safe. And it significantly improves physical function, shortens ICU and hospital stays, and directly fights that muscle wasting. Prolonged bed rest is just terrible for muscles. It massively accelerates atrophy and worsens ICUAW. Beyond that, it's about excellent fundamental ICU care, preventing DVT and stress ulcers, using sedation judiciously to avoid oversedation, and aggressively managing infections. All these support recovery and minimize complications that contribute to weakness.
So, wrapping this deep dive up, what's the big take-home message for clinicians dealing with these patients day in, day out?
I think the bottom line is that neuromuscular disorders, whether they're the primary reason for admission or they develop during the ICU stay like ICUAW, they demand a really high index of suspicion and just meticulous attention. Recognizing those early signs of respiratory muscle weakness, understanding the subtleties of the diagnostic tests, and really tailoring treatment to the specific disorder and the individual patient, that's paramount to improving outcomes.
Ultimately, it sounds like mastering these conditions is about providing that vital bridge to recovery, often against a backdrop of really profound weakness and potential long-term disability. It's about being vigilant, proactive.
Right. And maybe this raises an important question for the future. As our understanding of the immune system and its role in so many of these disorders continues to deepen, how might these increasingly targeted therapies continue to revolutionize critical care management, even beyond what we can do today? Something perhaps for you to think about as you continue your invaluable work at the bedside.